Hi everyone, welcome to our webinar this evening. I've just pressed the record button and we will allow everyone to join. You're very welcome and thank you for joining us on this lovely sunny evening. I hope you've had some chance to get out and enjoy it today. So just bear with us for a moment as people continue to join and we'll get started very soon. Okay, I think we can get started now. Let me pull up the intro slides and we will move on to our speakers then. So thank you very much for joining us this evening for our topic on care of patients with cancer in the community, treatment and survivorship. For those of you who are familiar with our webinar series so far, you're all muted as you join us. You can choose to have your cameras on or off as you choose. We've pressed the record function and the recording will be made available on the website after the event, and you'll be sent the resources, the slides from this webinar as you register to attend. The chat function, you're very welcome to use it throughout the webinar this evening. So if you just hover over your screen, just at the very bottom of the screen, you'll see the chat button and you can ask questions in there. The speakers will be happy to answer questions at the end of the session. But if you have a burning question, please do type it in there and we can store them up and pose them to the presenters at the end. So turning to our speakers this evening. We have 4 speakers this evening and who will speak on a range of topics relating to this subject. So we have Anne-Marie Dufresne, Deputy Chief Pharmacist of the National Cancer Control Programme, Claire Meany, Senior Pharmacist, National Cancer Control Programme, Elizabeth Breen, Chief 2 Pharmacist of the National Cancer Control Programme, and Louise Mullen, National Lead for Cancer Survivorship with the National Cancer Control Programme. So as you can see, a range of guests and from Louise from outside of the pharmacy profession and will bring some very interesting information relating to survivorship that I'm sure will be very useful to our practice as pharmacists. So without further ado, I will hand over to Anne-Marie, who will get started on the webinar this evening. Thank you very much, Anne-Marie, and I will mute myself.
Thanks a million, Mary Claire. I'm just going to share my screen. So just to make sure and let me know that you can see this okay. Is that okay?
Perfect. Yep.
Super. So yep, as Mary Claire said, thanks a million to everyone for joining this beautiful evening. And you're very welcome and we're delighted to be here to speak to you this evening, whether that's now or whether it's later on, I suppose. You know, we're very happy to talk to you, particularly about this topic that's close to all of our hearts, you can imagine, working for the NCCP. And what we specifically wanted to talk to you about was, you know, care of patients with cancer in the community, and not just from the treatment aspects, but broader than the actual chemotherapy treatment or the actual treatment for their cancer, but much more with the focus on the supportive care elements of their treatment. And also then, you know, our colleague Louise, who will speak to you more about survivorship, because luckily what we are seeing in this country is an awful lot more patients living with cancer for much longer, as well as living after their cancer diagnosis. And Louise will talk to you much more about that. So if I just give you a brief overview of what we hope to talk to you about this evening. I'm just going to give you a brief introduction to the NCCP and to cancer services in Ireland generally. And then more specifically, my colleague Claire will talk about some of the resources that we as the NCCP have put in place to try and support you as you care for those patients. Specifically, Claire will mention our national chemotherapy regimens, but we don't plan on really dwelling enormously tonight on the actual treatment with oral anti-cancer meds or systemic anti-cancer meds for cancer. We plan to focus much more on the other parts of it. And Claire's also going to just talk you through this community pharmacy resource page that we've put in place, with some things that may help you if you come across patients or if there's a particular queries or areas you're more focused or you're more interested in learning more about. And then between Claire and Liz, they're going to focus on some of those supportive care areas. So that will be specific things that are looked at to counteract some of the drug toxicities. So we'll focus on things like the antiemetics for the nausea and vomiting, some of the constipation, diarrhea, the use of PPIs, much more of the types of things that you'll see in the community setting, because you'll be dispensing a lot of these medicines to patients. So regardless of whether the patient is receiving, well, either maybe post-surgery radiotherapy or chemotherapy, be it in the hospital or they're on oral agents, they'll all be on various supportive care elements as well. So it's, much more that they're taking those at home is what we're seeing. Liz is just going to give you a brief update on one particular oral anti-cancer agent, lenalidomide. Just in recent months, there's been a number of generic products launched, and just to flag maybe the pregnancy prevention program associated with them, we thought it'd be a great opportunity just to give you an update on that. And then we'll hand over to Louise, who is our national lead for cancer survivorship, and she'll bring you through some of the more interesting elements of survivorship. It's a hugely evolving area, and I hope you find it useful as well. So just briefly then to mention, so the NCCP is, the National Cancer Control Programme. So it is a national programme concerned, with the planning, the organising and the delivery of cancer services in Ireland. It was established back in 2007 with the aim of implementing the cancer strategy from 2006, actually. And there's a cancer strategy done by the Department of Health about every 10 years. So our more recent cancer strategy in 2017 is really the main aim of the NCCP is focused on implementing the recommendations contained within that strategy. I thought it was important just to flag that the NCCP is about much more than drugs and chemo and the medicines for the treatment of cancer. It actually looks at the entire cancer continuum. So if you see my little diagram here, the cancer continuum really starts with the prevention of cancer. It works through to the early detection. And you may recall last year how some of our colleagues that work in the early detection program would have spoken to you about lung cancer. Then there's the diagnosis elements, and then more relevant to our world as pharmacists, I suppose, is the treatment elements. And then, as I said, the survivorship part, which is, that full circle. Unfortunately, for some patients, they do go over to the palliative care or to the end of life. And there is a separate national program that deals with palliative care, and the likes of the Irish Hospice Foundation and those. So we don't really focus on that within the NCCP, but we do have programs that look at all aspects of the continuum. From ourselves, particularly, we work within the program that is concerned with medical oncology and hematology services. So that's the systemic therapy program. And the main aim of that is really to ensure that we have quality and safe services for the provision of SACT. So SACT is systemic anti-cancer therapy, and it would have traditionally really been chemotherapy. But, in the last 10 years, particularly, there's been a massive kind of a shift in treatment, in that we have much more targeted therapies, immunotherapies, and other treatments as well, like, the newer hormonal agents, particularly those used in prostate cancer. So there's been kind of a move with that away from the use of traditional chemotherapy and much more towards systemic anti-cancer therapy, or SACT. So you'll often hear us talking about SACT, and that's what we mean. We're including targeted immunotherapy, the newer hormonal agents, as well as the more traditional chemotherapy. So from the systemic therapy program then, so we're a relatively small team, I suppose. We've about maybe 10 or 11 in our team. Where there are a number of us that are pharmacists. We have 2 amazing technicians as well within our team that support us. And how we try and support quality and safe services in medical oncology and hematology in Ireland is, through the development of some national guidance documents and some other national resource documents. And one of the key ones of these was kind of a baseline assessment of what was going on in terms of SACT services in the hospitals. And we did that document back in 2014. It was the Medication Safety Review Report. And a key finding from that actually was that we needed to look and focus much more on oral anti-cancer medicines. And so we did that through a working group, and we published a model of care for oral anti-cancer medicines in 2018. In that, we recognized that we need to do a lot more to support community pharmacists, particularly in in enabling patients to kind of empower them to support them in around the education associated with those drugs. But we very much recognize that for most community pharmacists, you may not see very many people on OAMs. So, what we did was recognize that you can't know everything about everything. Indeed, nobody does. So we just wanted to make sure that you were all aware that we develop national treatment regimens, and we have those in place for orals and for IV agents and for combination agents. So if you do come across a prescription such as that, you can go to our website. Those regimens are accessible to everyone. And we are like continuing, like we did with last year with the IIOP. We worked on an education piece for OAMs as well for everyone. And we will continue to try and work in this space. So we do continue to support pharmacy cancer services. We do try and look to the future and think more strategically about what else could support, the healthcare professionals that are looking after the patients, be they in the community, in the hospital, or elsewhere around services. Another one of our roles, we are involved in the HSE standard assessment process for new drugs, and this would be around the reimbursement of those new drugs. So you may be aware the NCPE carry out health technology assessments, but there are a lot of other steps involved in reimbursement considerations, and the NCCP and our team play a part in that when it comes to considering cancer drugs. As a result of a lot of that work, we do get a lot of queries, and they may be anything from, from the Department of Health, they may be from the press, they may be from patients themselves or their families, and from all sorts of healthcare professionals. And we're always welcoming of those queries, so, anyone, if at any stage you have a query, do feel free to get in touch with us. My last point is just, I suppose it's important to think of the principles of Sláinte care as we look towards the future. And one of those would be that we need to, support patients to be treated in their choices. And very often that is closer to home. What we're seeing, is maybe this perfect storm where we're seeing lots more oral chemotherapy and oral anti-cancer medicines come on the market. We're seeing lots more patients, and unfortunately after COVID we're seeing patients being diagnosed at later stages and needing more treatment probably than they may have had they have been diagnosed earlier. So we're seeing more patients needing more treatment. We're seeing lots more oral agents or oral agents in combination with IV agents, and we're likely to see a lot more patients coming through your doors. The good side of that too is that a lot more of them are surviving for much longer and doing really well. They're staying on treatment for longer, I suppose, but they're also seem to be doing well. So as we look to the future, we do need to consider the best ways to support our patients, and that is maybe with a nod to treating them closer to home or keeping them at home for as long as possible. So there's going to be plenty of roles and plenty of work for all of us, I imagine too. With that, I'm going to hand over to Claire, and Claire, you just give me the nod in terms of the slides.
Okay, thanks, Anne-Marie. So I'm going to talk about the national chemotherapy regimens, which Anne-Marie alluded to, and which is one of the work streams within the systemic therapy program. And these are evidence-based documents, and they're designed to support the safe and cost-effective cancer treatment of all Irish cancer patients. We have quite a robust process in place for the development of these regimens, where we work with a lead clinician to develop the regimen, and it follows a standard NCCP template. And at this point, we've developed a number of regimens in medical oncology for the different solid tumors, such as breast, lung, and in hemato-oncology for leukemia, lymphoma, and multiple myeloma. And once these regimens are approved, as Anne-Marie said, they're published on the website and they're made available so anybody can go in and access them. And they're divided out according to the tumor type on the web page. And I'll show you what the web page looks like on the next slide. And we've created a separate web page for the oral anti-cancer medicines also, so where we've collated all the regimens that have an oral anti-cancer medicine in them. So they're just all in one place. So it might make it a little bit easier to find them rather than having to search through the different tumor types. So now we have over 500 regimens approved and published and covering over 630 indications. And these regimens cover the new drugs such as your immunotherapy agents and existing drugs that have been around for a long time, and new indications coming through the assessment process. And we have oral drugs and parenteral drugs. And this library of over 500 regimens, this has been built into the National Cancer Information System. And this ICT system is being rolled out across all the 26 hospitals which are involved in the administration of SACT to public patients. So this library of regimens was kind of the baseline work for that system. So the next slide. Thanks, Emery. So this here is an example of what a regimen looks like. It follows a standard template. On the left-hand side, here we have the different sections on the regimen. And you can see here, this regimen here, it's carboplatin, an IV agent with oral etoposide. And the first thing we have on the regimen always is the indication. It tells you what type of cancer it's being used to treat. And then the next section is the treatment section, which kind of details what are the drugs, what are the doses, how are they, and how is the drug administered to the patient. And then we have a number of other sections on the regimen. So in terms of eligibility criteria, it details dose modifications to manage toxicity. There's information around the supportive care that may be required and the adverse events associated with the regimen. But all of the regimens follow the same template, and any information that's relevant to the sections is included. So next slide, thanks. So here on the right-hand side here is the actual, this is what the NCCP chemotherapy regimen webpage looks like on the web. And so just gives you some background on the regimens, and then it has the list of the tumor types on the left-hand side of that page. And so you click into that and you find the different regimens that are there, and they're generally done alphabetically. And as I said, for the orally anti-cancer medicines, there's a separate section with all of those in there together. And this regimen here that I picked out, carfilzomib, lenolidomide, and dexamethasone, I suppose this one I picked because it's an example, as Anne-Marie said, of a regimen where we have a parenteral drug, carfilzomib, which is administered in the day ward in a hospital, and then you have the lenolidomide and the dexamethasone, which would be dispensed in the community setting by you. And it's just really to flag that while some of the oral anti-cancer medicines may be administered as monotherapy for treatment, sometimes you are only seeing in the community only part of the treatment regimen. The oral may be used in combination with a parenteral drug, and it was just to flag that. So really, my message just is to let you know that we have these chemotherapy regimens available. They're a resource, you can readily access them if you so wish, or if you're looking for information about a particular regimen. So then the next slide. So moving on from the regimens, this is the community pharmacy resources webpage, which we have developed, and we'd just like to draw your attention to, just to let you know that it's there. It's available on the NCCP website under the community pharmacy heading. And it's just been developed to highlight the different resources that are readily available to you if you're looking for more information on a particular aspect. Now, it has a particular focus on the safe dispensing of oral anti-cancer medicines and guidance on that. There's information on patient counselling, patients in cancer, and there's information on supportive care. The tables on the webpage link to relevant national and international resources on related cancer. So basically, it's just a repository of links really to information if you're interested in, that you can go in and click and read it and hopefully find what you are looking for. So then the next slide. So then I suppose moving on, this next part of the presentation, which Elizabeth is going to continue on with after me, is focusing on supportive care. And I suppose first off, just want to flag that there are many different aspects involved in the supportive care of a cancer patient across the entire cancer continuum, from the diagnosis through treatment to post-treatment care. And Elizabeth and I are just going to focus in the next few slides on the medications, many of which are dispensed in the community pharmacy setting and that are used as supportive care for the management or prevention of adverse effects associated with the treatment for cancer, or maybe the cancer itself. So we're focusing on the medications, which I suppose is to be expected from pharmacists. The next slide, please, Anne-Marie. So the first element of supportive care we would like to highlight are antiemetics, and as I suppose we're all aware, we're all aware of nausea and vomiting and associating that with systemic anti-cancer therapy. It's one of the most frequent side effects experienced by patients undergoing treatment. It has a significant impact on their quality of life. I mean, as we can all testify to. And the real key message with this is prevention. It's all about trying to prevent the nausea and vomiting associated with the treatment. So all of our regimens will detail the emetogenic risk associated with a SACT treatment. And we've developed and published an NCCP classification document for systemic anti-cancer therapy induced nausea and vomiting. And this document basically provides some background on the nausea and vomiting associated with SACT treatment, and it details the emetogenic risk associated with SACT drugs, and then the antiemetic regimens that are used to prevent and to treat the nausea and vomiting induced by systemic anti-cancer therapy. Next slide, please. This is my last slide, and here we have a table sort of detailing the classification of emetogenic risk of SACT drugs. And so top of the list in red, you've got your high emetogenic risk drugs, where you have greater than 90% risk of emesis. So as you can imagine, the person is more than likely going to be sick. So the antiemetic regimen is really important, and the type of antiemetic regimen and what needs to be included in it is detailed there. And I just want to flag, just from your point of view, the use of olanzapine. Olanzapine is not licensed for the treatment of nausea and vomiting, but it is recognized in international guidelines and the evidence is there for it to be used in combination with your NK receptor antagonist and your 5-HT3 receptor antagonist, something like ondansetron, your corticosteroid, to prevent the nausea and vomiting associated with high emetogenic risk regimens. So this just might be something that you may come across in the community pharmacy setting. International guidelines do recommend the inclusion of olanzapine in these antiemetic regimens. And then moving down, you have your moderate risk, your low risk, and then your minimal risk, where you have less than 10% risk of emesis, and where thankfully you need no routine prophylaxis is required usually. So thank you, and I'm going to pass it over now to Elizabeth, who's going to continue on.
Thanks, Claire. So as Claire had highlighted there, that the supportive care section of each regimen will highlight whatever supportive care additional measures need to be taken. So I'm going to talk about a few of those, and I suppose a few that it's just to give you a little bit of a background and understanding of why they're there. So I'm starting off at high dose steroids. So as we know, there's loads of benefits of low dose steroids in appetite stimulation, and as Claire had talked about, preventing or treating nausea and vomiting. But at high doses, they have other uses. So for example, in some treatment regimens, they're used as part of the treatment regimen. For example, in leukemia, lymphoma, and myeloma regimens. They have an anti-tumor effect in certain regimens. And they can also be used then to pre-medicate patients as part of the treatment strategy to prevent hypersensitivity reactions. And then they can also be used to treat the hypersensitivity, so pre-medicate to prevent and also to treat hypersensitivity reactions. And you could see that in patients who have reacted to paclitaxel or reacted to rituximab monoclonal antibody on the day ward, and they might be prescribed then that as an outpatient script for their next cycle, which you might have to dispense in community, and they bring it to the hospital with them. Or they take it at home before they go into hospital. Then it's also used to treat brain metastases as symptomatic relief. So they use to treat that by reducing intracranial pressure and or edema associated with the tumor. And then moving on to the other part of high-dose steroids use, they're used to manage toxicities associated with systemic anti-cancer therapy or associated with other treatments. So in immunotherapy, we know the newer drugs such as pembrolizumab, which we hear a lot about, or nivolumab and ipilimumab, they are called immune checkpoint inhibitors, and these have transformed cancer treatment over the last decade. So high-dose steroids are used to treat the adverse effects associated with immunotherapies. And then we also have graft versus host disease, which you've probably heard of, and this is used as an anti-inflammatory effect in patients and through their immunosuppressive effect. So graft versus host disease is a cause of morbidity and mortality associated in allogeneic stem cell transplants in patients. It's when the donor cells, they recognize and attack the host tissue in the immunocompromised recipient of the donor cells, and typically it presents as an inflammation of either the skin, the mucosa, the gastrointestinal tract, the liver, or the lungs. And then immunosuppression is used as the first line of treatment for these management of these patients who experience graft versus host. So you may see patients on these high doses for a long duration of time, and then that will be tapered down over time as they overcome these side effects or toxicities. And then on the right-hand side of the slide there, you see side effects. So these side effects, I suppose, are more associated with the higher doses. They're associated with steroids in general, but they're more so with the higher doses. You might see withdrawal. You may see patients with steroid psychosis, steroid-induced psychosis. And as Claire talked about olanzapine, again, olanzapine is used for steroid-induced psychosis in some patients. It's a low dose, and it's one of the atypical antipsychotics that is used to alleviate or mitigate the symptoms of steroid-induced psychosis. And then we have infection risk, which is associated with long use and high doses of steroids. And then we also have insomnia, which is one of those side effects that everybody knows about. So then moving on to the next slide. So this is a nice diagram that describes all the different types of immune-mediated toxicities associated with immunotherapy. So immune checkpoint inhibitors, as I mentioned, like pembro and nivolumab, they target the immune system. They target the immune system by targeting the immune checkpoint receptors such as PD-L1 or ligand or CTLA4. And they cause the immune system to attenuate and have an anti-neoplastic effect on the tumor cells. But if they're going to attenuate the immune system, that's also going to have some sort of a negative effect. And the majority of patients will experience some sort of immune-mediated toxicity, and they're called the itises because it's pneumonitis, hepatitis, colitis. And these drugs are usually received in hospital as the immunotherapies, and then as they are diagnosed with this immune-mediated toxicity, the patients will then be discharged home if they need to be admitted, or they can be managed as an outpatient, and high doses of steroids are prescribed and then weaned off once the patient has recovered. The majority of these immune-mediated toxicities occur early on in their cycle of SACT treatment, and it's usually within the first few weeks to 3 months treatment. But there has been reports of patients having their first onset of toxicity up to 1 year after they've discontinued treatment. So I suppose as a community pharmacist, it's good to be aware of the patient's history of their SACT and their cancer treatment in case they present with some sort of atypical symptom like a fatigue or a headache or diarrhea. And sometimes that might require further investigation, or it could just simply be a straightforward side effect or just something that they're experiencing right now. But it's always good to get that checked out by the hospital. And then on the NCCP regimens for those immunotherapies, there is a treatment algorithm documented, and then there's the management recommendations included as well. So if there's any kind of question about the steroids or why they're prescribed those doses, you might see that on the regimen, and that's documented in the supportive care section. So next slide. So proton pump inhibitors, we all know about proton pump inhibitors. So radiotherapy and some SACT medicines, they can interrupt the rapid growth cycle of cancer cells, and they also affect normal healthy cells. So as a result, intestinal epithelial cell turnover can be affected. And as mentioned in the previous slide about steroids, patients may be on high dose steroids, and they again may have gastric and mucosal damage or irritation due to the steroids or due to their radiation or SACT therapy. So to prophylax against that, patients will be prescribed some sort of stomach acid protection, and usually you would see, typically you would see lansoprazole or esomeprazole, but you would see other PPIs. Well, I just made a note of those two, which would be the most common ones we would see. So it's important to protect the stomach while the patient is on treatment. It wouldn't necessarily be lifelong, it's just while the patient is on treatment. So next slide. And then Gcsf. So neutropenia is a common side effect after patients have received chemotherapy, and it's associated with an increased risk of infection. And this can lead to neutropenic sepsis, which can be fatal if it's not managed swiftly. Gcsf, as we know, is used to prevent or to treat profound neutropenia and treat infection as well. So patients are usually prescribed this as part of their SACT regimen, or it may also be added to their treatment if they experience neutropenia over time and have had to have their treatment postponed a week or two to allow their counts to recover. There are many benefits to using Gcsf. For example, it reduces the incidence of infection in patients, which therefore will reduce the number of people being hospitalized as a result of neutropenia. And this leads to better outcomes because patients don't have as many dose delays, and they don't need as many dose reductions because their neutrophil counts are being managed well and being maintained. And then on this slide, just want to highlight the differences. You know the difference between the short-acting and the long-acting. So the short-acting Gcsf, it's a once daily injection, and it's used for a specified number of days, and that's used both in solid tumor as well as hemato-oncology patients. The long-acting one is the one I want to talk about a little bit more, because it's not usually recommended in certain regimens for example, some hemato-oncology, or most hemato-oncology regimens will not use the long-acting because of its duration of action. And also weekly treatment regimens such as weekly paclitaxel and breast will use, if they need to use Gcsf, they will use the shorter acting rather than the longer acting. So the graph here on the right, it's on the Neulasta SPC, but it just gives you a nice diagram, I feel, of how and when Neulasta kicks in, and then the neutrophil count when it recovers. So that's why you wouldn't necessarily give Neulasta in a weekly patient, because of the fact that they will be starting chemo the following week and they will just get hit with more chemo, and the neutrophil counts might be, I suppose, pseudo up or pseudo high in a way. And then talking about the side effects, patients often talk about the side effects of Gcsf, particularly the bone pain. So the hospital, when the patient's been, advised when they start treatment and during their treatment, they'll be, advised whether they can use, particular bone pain relief. So they can use paracetamol, but they might not want them to use paracetamol at all, because then that might mask the fever of a patient who may have an infection. So they might then instead prefer them to use ibuprofen, but normally they will always be asked to contact the hospital if they have any questions, or if they want to use, or if they have concerns about using some pain relief. But normally ibuprofen is the first protocol for the pain relief. And then also other side effects include nausea and headaches. So as a pharmacist, I suppose if the patient complains about bone pain, you can always advise them, just give the hospital a ring, and just to find out what they can or can't do, if they need to do anything further. So next slide, Anne-Marie. And then constipation and diarrhea. So there are a number of factors that cause constipation or diarrhea in patients undergoing treatment or following treatment from cancer. The cancer itself may cause obstruction, or it may cause diarrhea. And as previously mentioned, some SACT treatments can interfere with cell turnover in the gastrointestinal tract, which can also have an effect on their gut motility. So antiemetics or other supportive medications that I've listed there on the slide can also cause diarrhea and constipation. So you see on the left there, constipation, you've got vincristine, which is well known to cause constipation. Typically, patients will be prescribed or recommended to take a laxative if they need it after treatment. And you've also got your antiemetics, your ondansetrons, well known to cause constipation, and then your opiates. And then on the right, diarrhea. There's a good few of the SACT medicines that cause diarrhea. And I just want to note there's a relatively new drug called neratinib that's used for breast cancer. And one of its side effects is well known. Its most common side effect is diarrhea, and it's quite a heavy complaint as well from patients that have been on trial and that are use it. So as part of the treatment regimen, patients are prescribed loperamide as prophylaxis for the first 2 months of treatment, and they're monitored for the side effect of diarrhea in those patients. And then also previously mentioned, immunotherapies can cause colitis. So again, all these different things can affect a patient and interfere with their quality of life. Patients may also need to adapt to a new lifestyle following surgery or SACT or radiation, which may impact the GI tract. Might mean diet changes. It might also mean that their activity levels are lower than they used to be, or they've had surgery for some sort of resection, and that is going to impact the way they move forward. So in general, again, you can speak to patients from a pharmacist's perspective. You can speak to patients and support them and encourage them to record their symptoms and report back to the hospital to ensure that if they are receiving their most appropriate treatment, if there's something that you might be concerned about or you feel that is associated with their SACT treatment or their cancer treatment. Next slide. Now, the next few slides are about infection prophylaxis. So you probably will see on regimens that some patients will need antiviral prophylaxis. So in certain regimens that patients will be treated with, like lymphomas or leukemias, or patients that will be undergoing bone marrow transplant, if patients are treated with this and with their induction therapy or their intensive therapy, it may reactivate their previous infection of herpes simplex virus or their hepatitis B or C. And this is a known cause of morbidity in patients. So prior to any patient receiving treatment, once they're diagnosed, they would usually be screened for these infections. And if there is a positive test on any of those screens, the patient will then be initiated on some sort of a prophylaxis therapy. But that would normally be in consultation with the infectious disease team. And a couple of examples of this would be for herpes simplex, they would be prescribed acyclovir as prophylaxis or valacyclovir as prophylaxis. You will also see patients being prescribed for hepatitis B or C, lamivudine or entecavir as well. And these drugs would be continued while the patient's on treatment, and they would be reviewed regularly by the team and whether they need to stop post-treatment or not. The next slide. Then we have the antifungal prophylaxis. So again, patients such as leukemic patients and those who've got high risk myelodysplastic syndrome, and also those patients undergoing hematopoietic stem cell transplantation, they're all very high risk for infection, either because of their treatment, which knocks out their bone marrow, or because of the disease, which has impacted their bone marrow. So I suppose prior to COVID, you would have seen these patients wearing masks in public. And this was especially important when these patients were outside and near any sort of building site for the risk of inhalation of spores. So the risk of infection is associated with the duration and the severity of the neutropenia, the number of chemotherapy cycles that they're going through, and then also the prolonged antibiotic use that may be associated with their treatment. Or they may have, bouts of neutropenia, they might need an antibiotic on top of that. So prophylaxis is normally initiated for these patients at induction, and the following drugs are a typical list of what they would be on, but these would be prescribed based on their neutropenic risk, and also there would be other factors that would need to be considered by the team before they use one of the antifungals. So fluconazole can be oral or IV, posaconazole is the same, voriconazole IV, caspofungin is IV, and some of these will either be given in hospital as an IV, as an outpatient, or the patient might be prescribed the oral, and that would be dispensed in the pharmacy. So we're all fond of drug interactions, and we know that these antifungals cause a lot of drug interactions. So that's one thing that we need to be conscious of when we are screening and verifying prescriptions for SACT in hospital and also in community when patients present with their prescriptions. Then next slide. And then supportive care. So this is just a brief description of Pjp prophylaxis. So pneumocystis jirovecii, I don't know if I got that right, it's pneumonia. It's rare, but it's quite opportunistic in patients. And it has a fairly high mortality rate in patients who have got hematologic malignancies or they're after a stem cell transplant. So prophylaxis is normally prescribed one of these drugs, or two of these drugs may be prescribed. And again, that would depend on the team and knowing the patient's risk. And as you know, these are dispensed in community, but the pentamidine that's nebulized is prepared and administered in the hospital. So again, this is just to give you an idea of the different types of supportive care that you would see on the regimens, and some of those things that are quite relevant to community pharmacy. So then the next slide. So this is just a lenalidomide update. You probably would have, and you probably are all aware of the changes recently. So the EU patent for lenalidomide expired Q1 this year. So there was 6 generic marketing authorization holders who had applied to Ireland to have their product on the Irish market. And one of the things that was noted when these MAHs were applying to Ireland was that they would all have to have a pregnancy prevention program as part of their licensing arrangement. And in advance of the launch of these products on the Irish market, it was noted that this could be a fairly big challenge for community pharmacists, for hospital pharmacists, and for clinicians prescribing these lenalidomide drugs. So the NCCP engaged with the HPRA and HSE to discuss what can be done, if anything can be done, to try and harmonise the system for the pregnancy prevention programme for these generic products. As a result, the HPRA engaged with all of the MAHs and they were able to harmonise the forms, which was great, and they are used across the board. And then within that harmonised system, there is a paper-based system and there's an online portal. So the Patient Safety Hub is the online portal. I imagine some of you have already used it. 4 MAHs are on that, and then there are 2 MAHs who have their own paper-based systems used. So then the next slide. And then as a result of all of this, the NCCP prepared a briefing note on the implementation of the pregnancy prevention programme for these generic products. And this is available on the NCCP website. It describes the key elements of the harmonised systems for all these generics. And there's a link that can be found on the Community Pharmacy Resources page for information if you want to have a better read. Then that's the end of myself and Anne-Marie and Claire talking. If you have any feedback or if you have any questions, our email address is there at the bottom of the screen. Anything related to SACT regimens, if you see something that you want to ask about, or something that maybe you could propose or suggest to us, we welcome all suggestions and feedback. And then as well as that, you can see, our website is there. We also have a Twitter handle if you want to follow us on Twitter. And I will pass you over now to Louise. Thank you.
Thank you, Liz. Thanks, Anne-Marie. I'm going to talk to you today a little bit about cancer survivorship and living with and beyond cancer. And the emphasis has been in the past, for example, in the 2006 cancer strategy, the word survivorship and the term survivorship was never used. Everything was about survival and the length of time of survival. But things have really changed in the ensuing decade. And the current strategy has a real emphasis on cancer survivorship. So what is it? Why do we have that emphasis? And how can we help patients and families who have come through a diagnosis and treatment of cancer? So one of the reasons it's become so important is that treatments have hugely improved in recent times, combined with early detection, and also the restructuring of cancer services has made a big difference. So many cancers are survivable, and survival rates in general have really increased. So our current strategy, you can see the vision there. The emphasis is very different, and there's a couple of reasons for that. So the emphasis is on quality of life, health and well-being, not just the absence of disease. And it has also an emphasis on patient experience and their outcomes. And part of the reason for this is in combination with a steering group who wrote this strategy was a cancer patient forum. And that sat in parallel with the steering group, and it hugely emphasized the sort of framing and direction of this strategy, particularly in relation to these areas that I've mentioned of quality of life and patient experience. So there's chapters on cancer survivorship and psycho-oncology, and also patient engagement and involvement in the strategy. So as Anne-Marie has said, this is our, what we're charged in the NCCP with implementing. So that's a little bit of background, and the emphasis in the strategy is still on prevention, early diagnosis, and treatment. But again, the framing of cancer survivorship and the importance of supporting patients and living with and beyond cancer is very much a part of it. The next slide. So to give you an idea about the prevalent population of cancer survivors, this statistic of 200,000 people is from the National Cancer Registry in Cork. And they have estimated the prevalent cancer population. And this is really an estimate of everybody who has been diagnosed with a cancer and is living in Ireland today. And we estimate that to be 200,000, which represents about 4% of the Irish population. And the other kind of thing that I want to emphasize about this pie chart as well is the 2/3 of cancer survivors is made up of three tumor groups, and that's prostate, breast, and colorectal. And these are all highly survivable cancers at this current time, over 80%. And the next slide. So this is a very general sort of schematic, but I'm just going to use it to emphasize a few points. So we define cancer survivorship from the point of diagnosis. And the reason for that is because it's very important. Some of the actions that are taken at diagnosis or at, for example, prehabilitation really have an influence on the post-treatment period. But it's sort of operationalized in the post-treatment period. So a person is diagnosed, they go through treatment, and they have a sort of an intensive period of follow-up just post-treatment. And this period of time, there's a lot of contact with acute hospitals and with oncology staff, and there's a lot of contact with the acute hospital. And then they move into a more extended survivorship period where there is surveillance. They might have scans once a year or different types of tests, and then they go to live with and beyond cancer. So next slide. So what we're very interested in is this sort of period of transition, because patients tell us that this is a really difficult time for them, and that and families find it too, that they often are asking themselves, what now? There's a feeling of kind of being cut off from that cocooning that they have when they have that kind of intensive contact with acute services. And they feel like they've fallen off a cliff, and they're really afraid to burden their family and friends, but very much people often struggle at this period of time. So next slide. So this comes from the National Cancer Survivorship Needs Assessment. And I'm not going to go through all these things, but these were identified by healthcare professionals in the oncology teams in our acute hospitals as the most common issues that were reported to them around for cancer survivors and in this post-treatment period. And the ones that I've ringed in red all correlate with what patients say are their most key issues. So that's fatigue, psychological distress or disturbance, and pain. So these are the other issues are common, but these correlate what the healthcare professionals say, they correlate with what patients also tell us. Next slide. So this is from the same study, and what we found was that most services, and these are the acute hospital services, have an identified point of contact for the patients, and this is usually the CNS, the clinical nurse specialist. They are given information about late and chronic effects, and a follow-up plan is given to their GP. And this is generally more around surveillance, so the clinical surveillance of scans and tests. But what they don't have is a survivorship care pathway. Rehabilitation programs, there are some, but they aren't common, and they don't have patient treatment summary and care planning. So next slide. So a person coming into your pharmacy may not have really been, may not have been made aware that they might be feeling this way in this post-treatment period, that they might be struggling, and that they might need support, and they might not really know where to seek that support. So one of the most important things that we're trying to develop is resources in the community to help people, and then also encourage people to signpost and let people know that there is help for this period of time that they might be undergoing. So this is one of our programs. It's called Cancer Thriving and Surviving, and it's based on the Stanford Model Self-Management Program, which was originally developed to deal with chronic disease self-management, but has been adapted for people who are living with and beyond cancer. And so it's a 6-week program, and it's held in many locations nationally. So I'm going to give you some resources in a minute to where you might find it. So I'm going to go through these quite quickly because I want to leave time for some questions. So this is one, Cancer Thriving and Surviving. It has a number of different names. The Mary Keating Foundation call it Survive and Thrive, but it's actually the same program. And the HSE have the Living Well program, which is the chronic disease version of it, but again, very similar. So this is an evidence-based program that was developed in Stanford. So next. Right. So this is another program. This one was developed, it's called Climb, which children's lives include moments of bravery. And this is a six-week program for children ages 5 to 12 who have a parent or a sibling or a significant other who's diagnosed with cancer. And this helps them cope, be able to talk about how they feel about the person's cancer, and also receive some peer support. So again, this is another program that we sponsor and is available nationally. Next slide. We have also developed a patient passport. This is a little bit more of a clinical piece, but it's patient held. And this is given to all patients with colorectal cancer. So this provides a kind of a record of their treatment, a record of their follow-up visits, and then also some adverse effects and issues that they might be having, and guidance around self-managing the after effects of their colorectal cancer. And the one on the right is called LACES, and this is a new program. This was only developed last year, and this is a collaboration with the Irish Cancer Society. And this is a post-treatment workshop. So this should be available to all cancer patients nationally because it's currently virtual, even though it was initially designed to be in person. And what it is it's a signposting and information workshop to resources in the community. So it's run in conjunction with the daffodil nurses and the oncology CNSs in the team. And it has different modules that deal with physical activity, nutrition, sexual functioning, psychosocial health, and it sort of signposts patients. It helps them to recognize what might be happening to them in the post-treatment period, and also signposting them to supports that are available in the community. So next one. So where would we find some of these supports? And if you recognized it in somebody who came into your pharmacy that you know who's gone through a cancer treatment, and you might sense that they're struggling. So community cancer support centers are voluntary and charity organizations that exist in every county in Ireland. And there's almost, well, there's about 47, over 40 in number. And they differ in size. Some are small groups, which are kind of based on peer support, and others are large professional organizations. And they really are de facto community support services for cancer patients in the post-treatment period. And so what do they offer? They offer the survivorship programs that I mentioned earlier. Not all support centers will offer all programs, but many of the big ones and the small ones as well will offer these programs. They have physical activity programs and some have gyms. They often have peer support groups and peer support activities. They have access to professional counseling, and some have MLD services for lymphedema. So they're a great resource to you, and they're a great resource to cancer patients and their families. They have the widest inclusive and accessible nature. So their programs are free. They welcome any type of cancer patient, and the families are welcome as well. And some of the centers have pediatric programs as well as adult programs. So how do you find them? So you can access them directly by just looking them up on the web, or you may know them already from your local community. There's information and signposting through the Irish Cancer Society support line and their websites. The individual centers have websites. The NCCP will have lists of, particularly when the programs where the programs like Cancer Thriving and Surviving will have lists of when they're being run and how to access them. And the ICS has the website, and Mary Keating Foundation also has a good website and a directory and a lot of information about cancer survivorship on their website. Next one. So currently the NCCP is drawing these community cancer support centers and services into an alliance. So this isn't completely launched yet or formed, but we're working hard with the services to make them more available, to expand their services. And we have a national best practice guidance that the cancer support centers and services are signing up to, which will provide a kind of a standard and an assurance to people who are referring to them and want to access them. So that's kind of coming in the next few months. Next slide. So in conclusion, I want to leave a couple of minutes for questions if anybody has them. Cancer survivorship is recognized priority in our national cancer strategy, but it will take resources and a sustained effort to build and deliver these services. They're not really all there, and we need them in both the acute and community settings. But many healthcare professionals, including pharmacists, have a real role to play here. And this is mainly so that patients know that there is this support, and families know that there is this support, and to be able to signpost them to it. And again, cancer patients' needs are individual and dynamic, but we can help them, and we can help them by providing treatment and management of common consequences, listening and giving guidance, and empowering patients and families to self-manage and to live their best life after their cancer diagnosis and treatment. Thank you.
Thanks, Louise. I suppose, yeah, I'll just wrap it up. I'm very conscious of time. We thought we'd be much faster, but just huge thank you to everyone. And I suppose, Mary Claire, will I hand it back to you perhaps to see if anyone has questions? I mean, I suppose while Mary Claire is coming on, I just want to say, that it's well recognized that pharmacists, be they community hospital or otherwise, are a hugely trusted healthcare professional resource for patients, for all people, but for patients in particular. Your patients may talk to you much more readily than they may talk to their hospital team or to anyone else, So we just thought that we would bring you a selection of things that they may raise with you, just so you know of it, and just to let you know that we have as much that we think may be of use on our website. And as Liz mentioned, we're always open to feedback if you think there's something that you'd like to see more of.
Thank you very much, Anne-Marie. Would you like to plug the webinar next week for yourselves?
Yes.
Excellent, thank you.
Thanks, Mary Claire. Lunchtime webinar next week on early detection. So just if anyone's interested, it's just the early diagnosis of symptomatic cancer plan. Again, another area that we see huge potential for community pharmacists, for those patients coming into you with the sustained cough or with strange lumps or bumps or all sorts of things. So it's actually on our website as well, in case you can't read the webinar.
Lovely, thank you, Anne-Marie. So we've had quite a few questions come through in the chat, and for the advantage of those people who are listening to this on a recording, I'll try and gather up some of those questions and answers and post them alongside the recording as well. I don't want you to miss out on some of those good answers that have been provided. Maybe just one thing I'd like to pick up on. Firstly, thank you to our 4 speakers. I've learned lots about the information that's out there that I didn't know existed, and how easy it is to find and how well organized it is to find. So obviously there's a lot of work been done in the last kind of 5 to 10 years in this space, and it's fantastic to see it. So thank you for highlighting that, and also to Louise about highlighting those community cancer supports that, again, you know, I was generally aware of them, but maybe not of the depth of what is available to patients and what we can recommend to patients if we identify that they're struggling. Just one question I maybe wanted to revisit around information that's available to patients on their specific regimens that they might be receiving. To what extent is that information available through yourselves or maybe through the treating hospital? Do you have any information on that?
So we don't really develop patient information leaflets because it is done usually at the hospital level, and a lot of that is supported through the Irish Cancer Society and through the hospital nurses, and there are all sorts of networks at local hospital level. Our focus really is on supporting the healthcare professionals looking after the patients, so that's why you'll see that all our regimens are they're in the healthcare professionals section. But yes, each patient should always receive some level of information and education about their own regimen, their own treatment plan, and they should always be given paper copies to support that, and that will be done in the hospital usually by the nurse educators and that there.
That's fantastic, thank you. So while if anybody's any further questions, please do feel free to type them into the chat. I am conscious of time. Just so you know, there is a link gone into the chat box there for any feedback that you have on this evening's webinar, and also if you'd like to suggest topics to us for future webinars, you can do so through that link that's provided there. Just to conclude then, I might just pull up our concluding slides. I see questions coming in here, so while we're pulling up the concluding slides, we will go through this question. So is there a standardized dosing for Septrin for Pjp prophylaxis and fluconazole for AV prophylaxis? You're welcome to answer that after the session. If you don't want to answer that now, we can post it in the comments afterwards, or if you feel like taking it now, whatever you wish.
Short answer, there's 2 different, I suppose, dosing formats that are used, and it varies. There's evidence for both, but there is 2 different. You would see 960 or you would see 480 twice a day, Monday, Wednesday, Friday. But again, 960 is probably preferred, but you would see 480 in some patients. That's a short answer. I can give a proper answer afterwards.
That'd be great. Thank you very much, Liz.
And then what the other question was? Fluconazole.
Yeah.
Mm-hmm. Yeah. Again, that's dosing. Again, it's local preference. Maybe there may be a reason for it, like with the local micro team. And again, there is evidence for both, but normally there is a reason. That's why we say refer to local policy in some of our regimens, because there is decisions made locally for some reasons. But again,
thank you.
I'll give a better answer. Thanks.
Yeah, it's clearly quite a detailed answer. So thank you very much for taking it though. So as we mentioned, the feedback link is provided in the chat box to advertise our webinar for next week. So due to speaker availability, we're having a webinar next week, and that's revisiting the topic of the Falsified Medicines Directive with Leonie Clark. So obviously she's going to give some updates on where we are in relation to the implementation of that within pharmacy. So it's quite topical at the moment. So we will advertise that through our usual formats, through email, Twitter, LinkedIn, and Instagram. So feel free to sign up to that, and that will be advertised from tomorrow. So without further ado, thank you very much to everyone for attending this evening. It's been very helpful, and thank you again to our 4 speakers for putting together that content and taking us through it so expertly. We're very grateful, and we're always delighted to have you here with the Irish Institute of Pharmacy. I know you've delivered a topic for us previously, and it's always expertly done, so thank you. So there's
Thanks,
another,
Mary-Claire. I'd say you'll see us again in June as well.
I think,
Not
yes,
us particularly, but some of
yes.
our colleagues. Yeah.
We do have a session planned on cancers in men coming up in June. So we'll advertise that in due course. So you're doing fantastic work for us. Thank you. So there's another question coming here. Has consideration ever been given to listing the parenteral hospital administered part of patient chemo regimen alongside the oral part of the regimen on high-tech prescriptions, so community pharmacists, sorry, scrolling down, would be aware of interactions? So having an awareness, I suppose, of the hospital regimen. Are you aware of any work done on that, or maybe any reasoning behind that?
Yeah, there's been a lot of work really around discussions of the high-tech prescription, but I suppose the high-techs were done from a reimbursement perspective and are much, much more broad than cancer. There was a lot of consideration in the oral anti-cancer medicines model of care, and we do try and recommend that all the relevant information should be included in the prescription, but yeah, let's say work in progress maybe. Is aprepitant supplied to patient on the day ward? It may or may not be. It varies according to the local hospital practice for that one. Sorry, on the aprepitant.
Thank you, Anne-Marie. Okay, so I don't spot any further questions coming through, and I'm aware we've kept everyone 5 or 6 minutes over. So I will stop the recording there.